All right, welcome to everyone in the room and on Zoom. I'm Sarah Alger. I'm the director of the Russell Museum here at Mass General Hospital. If you haven't attended one of our lectures before, welcome. So before I introduce tonight's speaker, just a few things. Just want to tout two upcoming events. We actually have one tomorrow here at noon. You can come in person or join by Zoom. This month is National Poetry Month, and tomorrow is the 7th annual celebration of poetry here at Mass General. We're co-sponsoring it with the MGH Writer in Residence program. There will be a number of people with string instruments playing, so music. Not only will there be poetry, there will also be some music and some visual art going on. And if you choose to join by Zoom, just go to the homepage of russellmuseum.org and you'll see a little flyer for poetry. You'll find the Zoom link right there. And then on Wednesday, May 28th, our next evening lecture is by Bruce Rosen, who runs the Martinos Center for Biomedical Imaging at Mass General. Their lab is over in the Charlestown Navy Yard campus, and they do crazy, incredible things over there with imaging. So he'll be talking about its past, present, and future, which will be really interesting. Just a note, after Dr. Mulligan is done, there'll be time for questions. Zoomers, just use the Q&A function to ask your questions. So Dr. Jennifer Mulligan is an associate physician as of November 2024 here at the MGH Weight Management Center, and she's an instructor at the Harvard Medical School. She is a board-certified family physician specializing in obesity medicine. She completed her medical education at the Medical College of Georgia, her family medicine residency at the University of Chicago, and her obesity medicine fellowship here at MGH. And at the MGH Weight Management Center, she specializes in medical therapy for obesity treatment for both adult and pediatric patients. With that, let's welcome Dr. Mulligan.
Thank you so much for having me. The topic that I wanted to discuss today is the current state and future direction of obesity medicine. First and foremost, I have no disclosures, and some aspects of this talk that I wanted to focus on are the effects of obesity nationally and globally, as well as the definition of obesity and how it has evolved over time, how we currently treat obesity, and how these new definitions and understanding of obesity may affect treatment in the future. So firstly, the definition of obesity as it currently stands by two of the largest organizations in the United States, the Obesity Medicine Association and the Obesity Society, describe obesity as a chronic, progressing, relapsing, treatable, multifactorial neurobehavioral disease where there's an increase in body fat that promotes adipose tissue dysfunction that can have adverse metabolic, biomechanical, and psychosocial health consequences. And the Obesity Society similarly describes it as a multi-causal chronic disease that can lead to structural abnormalities, physiological derangements, and functional impairments due to the development of excess adiposity. And so obesity is distinguished by multiple phenotypes. There's a lot of different ways that it can present, and there are different treatment responses to this. And the reason why we even care about treating obesity is that on a global scale, the prevalence of obesity has significantly increased over time. In 2015, over 600 million people, 600 million adults were affected, particularly noted in South Asia, Southeast Asia, Latin America, and the Caribbean. Women do generally tend to be affected more than men. And the pattern that we see is that high-income countries tend to be affected first, and then that's followed by middle and lower-income countries. Particularly in the United States alone, the rate of obesity has been doubling in both adolescents and adults since the 1990s. By 2025, so now we expect that 256 million, or 2050 actually, we expect that 250 million people will have overweight or obesity, and that in most states, 2 out of 3 adults are expected to have obesity. So more than 2/3 of people are expected to struggle with obesity. And I apologize, let's just say 2050, not 2025. The prevalence of obesity also is not distributed equally among different populations. In the United States, we see that generally minority populations tend to be affected more, particularly in non-Hispanic Black and Hispanic populations. There is also a significantly lower percentage of Asian populations that are said to have been affected by obesity. However, this number may actually be understated, and we'll talk about the reasons why. Socioeconomically, obesity is also not distributed evenly. Among different genders, so in women, a higher income has been consistently correlated with the lower prevalence of obesity, and higher levels of education has also been shown to be protective against obesity. But in men, income doesn't similarly correlate with the prevalence of obesity. And the obesity tends to be less prevalent in college graduates, but not necessarily those with some level of college education. Now, when we define obesity, we currently use BMIs to help us distinguish whether or not somebody has this disease process, as well as how severely they may be affected by it. And BMI is a formula where we compare the weight to someone's height. The reason why we use BMI is because it's generally very easy to obtain. You can go to your doctor's office and get weighed and get your height there. And so it's very easily obtained. You can track it over time every time that you go see your provider. It's replicable. It's very inexpensive. And the way that we classify the severity of obesity is that class 1, the mildest form of obesity, generally seen between a BMI of 30 to less than 35. Class 2, which is a moderate level of obesity, is between a BMI of 30 to less than 40. And class 3 is a BMI of 40 or greater. But there's a lot that the BMI doesn't actually tell us. So again, the formula for this is just that we're looking at someone's weight and comparing it to their height. But we're not really thinking about what that weight is composed of, that body composition. So when we think about what the body's weight is comprised of, fat mass is part of it, but we're not also including things, or we're forgetting to also remember that the weight consists of muscle, of your bones, your organs, and blood and water weight as well. And not only is it that the BMI is not perfect, but the criteria for obesity varies internationally. In the Western Hemisphere, and in Europe and Australia, the WHO, the World Health Organization, generally states that obesity is with a BMI of 30 and greater. And if you have overweight or pre-obesity, that's a BMI of 25 and greater. But in countries such as East Asia, so Korea, Japan, China, as well as the Asia Pacific region, the definition of obesity actually starts at much lower. So while the WHO defines the definition of overweight to start at 25, the definition of obesity in these Asian countries actually is the 25 for obesity, and having overweight starts at a lower BMI as well. And the reason for this is because compared to Caucasian populations, Asian people have been shown to have a higher visceral fat to subcutaneous fat ratio. So if you can see on this with this mouse, the subcutaneous fat is the layer of fat that's right under the skin. You have that pretty much everywhere across your body. But then visceral fat is the fat that lays underneath the muscles of your abdomen that protect your organs. Both types of fat are necessary for survival. However, higher levels of visceral fat have been correlated with higher risk of things like type 2 diabetes, high cholesterol, and high blood pressure. And why this higher ratio of visceral fat to subcutaneous fat may be occurring in Asian populations is debated. However, the thought is that there may be a genetic component. It may have to do with the diet. It may have to do with the level of physical activity, as well as just evolutionary history and potentially the culture that may have affected that as well. And so when we think about someone's weight and we think about why someone develops obesity, is it as simple as just how many calories you put into your body versus how much you put out? Is it the food intake minus the energy expenditure that leads to the net weight gain? So we wouldn't be having this talk today if it was truly that simple, and it's not. Obesity is a very complex disease process, and there's connections between your gut and your brain that we call the gut-brain axis that house hormones in the gut, and there's hormones in the brain that communicate with each other constantly to determine levels of hunger and fullness. And so one pathway is called the anorexigenic pathway. That pathway suppresses the appetite. And the other pathway is called the orexigenic pathway that leads to higher levels of hunger. We call this a homeostatic regulation. And so these hormones that are going between your gut and your brain are supposed to be constantly in communication to, for example, let's say after you've had dinner, to let you know that you should not feel hungry anymore and suppress that level of hunger and increase your level of fullness. And then separately, there's another pathway in the brain that's called the hedonic pathway that deals with cravings, satiation, the satisfaction that you get after eating as well. And so this pathway is also just not in the gut and the brain, but it's also that there are hormones in your fat cells, in the pancreas, that all kind of communicate with each other to affect that level of hunger and fullness. And so when the equation is as simple as food intake minus how many calories you put out because of energy expenditure, it's really not that simple because there's so many other factors that are affecting those sort of decisions of how much food you intake versus how much energy you expend. So 99% of obesity is what we call a multifactorial disease process, meaning that there's not generally just one particular reason for why someone develops obesity. A multifactorial obesity has factors such as your personal history, the nutrition that you intake, the level of physical activity that may have changed over the years, your sleep and your mental health, potentially side effect of some medications that you may have taken, as well as just natural life changes that happen over the course of someone's life. So, in terms of personal history, your family history can contribute to about 40 to 70% of the risk of developing obesity in your childhood and in your adulthood. Having one parent with obesity has been shown to increase the risk of obesity as adults. And there's also been a theory, a hypothesis that had been presented back in 1962 by James Neal that's called a thrifty gene hypothesis that suggested that if you have a very strong family history of obesity, this may be because evolutionarily it was beneficial for your family to hold on to more weight, particularly in times of starvation, because if you're able to hold on to the weight more, then you are more likely to be able to pass those genes on to your children and to your grandchildren. So then you might still have that kind of evolutionary change today in the 21st century, but it may not be as beneficial for you now compared to maybe what it was for your ancestors back then. It's an interesting hypothesis. Truly, there's not enough evidence to really support this. However, it does go to show that family history does play a significant role in terms of your own risk of developing obesity. And then there's another aspect called obesogenic environment, where truly the environment that you survive in may have an impact on your risk of developing obesity. So for example, being sedentary at school or at work can be a risk factor because the level of physical activity has decreased. having access to fresh or processed foods or ultra processed foods can have an impact, maybe due to the cost of fresh foods or depending on the location of where you live, certain portion sizes, as well as finding time to eat in a busy day of work or at school. Having access to a safe space for physical activity can be a barrier to healthy weight, as well as your sleep duration and quality. If you don't have good sleep, if you have poor sleep and you're not sleeping throughout the night, or you're sleeping very small amounts throughout the night, that can impact that connection between the gut and the brain to potentially increase that level of hunger and decrease that level of fullness. And any also childhood or adulthood trauma can have an impact in that pathway as well. Then there are medications that someone might be taking that could have weight gaining properties. And there's a lot of different types. Antidepressants, antipsychosis medications are commonly known to potentially cause weight gain, but things such as antihistamines, beta blockers, insulin, neuropathic agents such as pregabalin or gabapentin, sleep agents, and oral steroid medications have also been shown to be weight gaining as well. But just because they have the potential to be weight gaining doesn't necessarily mean that if you are taking a medication in this category, that you will 100% certainly gain weight. And so if any of these medications are maybe something that you're taking, it's not advised to stop them, especially if you need it and it has been helpful for you, but rather talk to your primary care provider or any other specialist that you may see for these for the conditions that you take these medications, and potentially see if there's any alternatives. Life changes, natural life changes that happen over time are also risk factors. So, like I had mentioned before, women tend to be affected more with obesity compared to men. Women have more hormonal changes throughout life compared to men. One is pregnancy. So, weight gain during pregnancy is necessary. It is also normal. People should not be losing weight during pregnancy. But after pregnancy, you can have something called postpartum weight retention, where after the pregnancy, maybe you don't lose that weight. And this can be related to the hormonal changes during pregnancy, the excess weight gained during pregnancy, sleep deprivation from having a newborn, as well as any changes to nutrition and physical activity associated with being a new parent. And mental health, postpartum, particularly postpartum depression or anxiety, can all contribute. About 20% of women tend to retain about more than 8 pounds 1 year after delivering. And having weight retention after 1 year of delivery can contribute to weight retention or obesity 15 years into your future. Then some other changes, like menopause, is also something that happens specifically to women. This is where you have a decreased level of estrogen, and with the hormonal changes related to menopause, you can see an increased level of fat mass, decreased skeletal muscle, reduced bone density, and again, sleep disturbance can happen. So with menopause, there can be a change in the body composition that can increase the risk of developing obesity. And regardless of gender, everybody ages over time. And as you age, the body composition will also naturally change. Your muscle mass will decrease, your fat mass in comparison will increase, and it can be further exacerbated by lifestyle changes. So if we look at this diagram, you can see this young adult who may have a minimal amount of visceral fat, the one that's underneath the abdominal muscles, and may have a certain level of nutrition and physical activity. And then as they age over time, the level of visceral fat will increase, potentially further exacerbated by changes in physical activity and certain food intake as well. And then that goes on into further adulthood. So when we treat obesity, where do we start? I encourage you to think about obesity treatment as a pyramid, in that every level is an important level and should be stacked on top of each other. So depending on the severity of the disease process, based on your health risks and your BMI, we consider different therapies. The initial therapy for anyone who may be considering treatment for obesity is making lifestyle modifications, nutrition, physical activity. If that alone is not enough, consider intensive medical intervention, considering working with like a nutritionist or a dietitian, meal replacement plans, physical therapy, or personal training. For people who are considering medications, there is a BMI criteria that you have to meet. You have to either have a BMI of 30 and above without any other comorbidities, so any other health problems, or you have to have a BMI of 27 with an obesity-related disease process. And these include things like high blood pressure, so hypertension, high cholesterol, type 2 diabetes, fatty liver disease with fibrosis, or sleep apnea. Then a step above that are some medical devices such as gastric balloons. And then at the very top is surgery. And in order to qualify for bariatric surgery, you have to have a BMI of 40 and above without any other health issue, or you have to have a BMI of 35 with an obesity-related comorbidity, very similar to those that I mentioned, to consider medications. So when we treat obesity, it is a comprehensive treatment. It is not as simple as just picking up a medication or deciding to go into surgery and then thinking that that's all you have to do. You have to have dietary intervention. You have to have intentional physical activity, setting aside time in your day to really dedicate your time and effort into activity. And then if needed, we consider medical therapy and surgical therapy. I think surgery tends to scare a lot of people. It is definitely, not something that we should be taking lightly. But surgery can be a life-changing procedure, and it can be a life-saving procedure. There are three major types of surgery that are done at Mass General Brigham: Roux-en-Y gastric bypass surgery, the sleeve gastrectomy, and a duodenal switch. What you will notice with all of these surgeries are that there are anatomical changes happening in the stomach. So here, and here, and here. And what's happening is that they're clipping away portions of the stomach that houses a lot of hunger hormones. That's called ghrelin. And so there's not just an anatomical change to the stomach size, but there's actual hormonal changes that are happening from undergoing these types of surgeries that then affect that pathway that between the gut and the brain to affect levels of hunger, levels of fullness. So not only are these surgeries actually meant to reduce the size of the stomach and to affect the connection between the stomach and the intestines to maybe have less caloric intake, but there are hormonal changes that are happening, which is why it's considered a metabolic surgery. There are metabolic changes happening with these surgeries. And when we think about treating obesity and the goal of treating obesity, we have to think about why we're doing this and what is the weight loss for. So the purpose of treating obesity and inducing weight loss is to help with overall improvement of health. And even having just a 5% to 10% weight loss can help with preventing type 2 diabetes. It can help with improving physical function. It can help with the hyperglycemia, the high blood sugar levels associated with type 2 diabetes, high blood pressure, and it can help improve sleep apnea. And with further levels of weight loss, we can see also cardiovascular disease risk reduction, potentially treating type 2 diabetes completely, as well as treating fatty liver disease. So when talking about obesity, the goal isn't to try to get to any particular weight. And that weight has been previously and currently described as the ideal weight. So the concept of an ideal weight is that historically it was considered to be the healthy weight for someone's height. But the problem with an ideal weight is that, one, it doesn't really actually exist. it's difficult to calculate because there's a couple of different formulas out there. And so what one system in a healthcare system may tell you may be very different from what another healthcare system may say. It's also not universally applicable because, again, we're looking at just someone's weight, comparing it to their height without thinking about age, about gender, about lifestyle. And so the body will naturally change composition with age, but the height may not really change. And we're not taking that into consideration either when we're looking at this idea of an ideal weight. So instead of thinking about an ideal weight, we think about a healthy body weight, which is not a specific range or value. And instead, it's a value within the physical and functional context. What weight is it where you are able to improve your physicality, where you are able to see improvements maybe in your other health components, such as, if you have other disease processes, or maybe in your lab work. Medical therapy for the treatment of obesity has truly exploded in the past 5 years. There are medical options now that have not been around for very long, but there are a lot of medications that have been around since the 1950s or early 1990s into the 2000s. There's two main categories. Either the medications are specifically FDA approved to treat obesity, or they are used off-label, meaning that the FDA hasn't actually said that these medications are used to treat obesity, but we know that they have some weight-losing potential to them. The ones that are FDA approved include things like orlistat, Contrave, or naltrexone and bupropion, phentermine, Qsymia, which is a combination of phentermine topiramate, Gelesis, which is a medical device, and of course medications like GLP-1 therapy, Saxenda, which is a daily injection, Wegovy, a weekly injection, and then tirzepatide, which is a dual agonist of a GLP-1 and a GIP. These are specifically FDA approved to treat obesity. Some other ones that are used off-label include medications like metformin, which is actually used to treat prediabetes, topiramate, which is actually used to treat seizures and prevent migraines, zonisamide, which is used for sleep, bupropion, which is used to treat depression and tobacco use disorder, naltrexone, which is used to treat chronic opioid use disorder and alcohol use disorder, and again, GLP-1 therapies. However, these specific ones are Victoza, Ozempic, Rybelsus, Trulicity, and that dual agonist is called Mounjaro. So again, if you have to have a specific diagnosis of something else in order to be able to obtain these other GLP-1s in blue. So when we look at this diagram again and think about how much weight loss is enough, again, having even that 5 to 10% weight loss can have significant improvement to your overall health. Medications such as phentermine and topiramate, bupropion and naltrexone, that Contrave, that Qsymia combination, which is FDA approved to treat obesity, can meet that 5 to 10% weight reduction on average. Medications such as the GLP-1 therapies, liraglutide, semaglutide, tirzepatide, have been shown to have anywhere between a 6 to 23% weight loss, which means that we can see further cardiovascular risk reduction, improvement in hypertension, type 2 diabetes, and fatty liver disease. And then with metabolic and bariatric surgery, we see anywhere between a 20 to 40% weight loss, depending on the type of surgery. And so truly, we have to think about also the severity of disease that we're treating, as well as the different options that there are for it. So how do these medicines actually work to treat obesity? Again, obesity is a disease process between the gut-brain axis. So we're either wanting to focus on treating something in the brain or treating something in the gut. Preferably treating something in the brain, because truly that's where a lot of these hormones are working. So in the brain, medications like phentermine, topiramate, zonisamide, phentermine topiramate combination, bupropion naltrexone combination, GLP-1 therapies, and tirzepatide work in the brain to reduce hunger and to increase that fullness and satiety. Other medicines, such as Gelesis, occupy physical space in your stomach, so it works peripherally. Orlistat actually decreases the fat absorption and doesn't have any impact in the brain. And uniquely, GLP-1 therapy and tirzepatide not only work in the central nervous system, but also slows down gastric emptying in your stomach so that you feel that sensation of fullness much quicker. There are also a lot of other benefits to using GLP-1 injectable therapy. Semaglutide has a couple. As of March 2024, Wegovy, which is FDA approved to treat obesity, was FDA approved to also reduce the risk of cardiovascular events in adults with obesity and overweight and established cardiovascular disease. That means that you yourself have to have a personal history of a myocardial infarction or a heart attack or a stroke. And as of January this year, Ozempic, which is FDA approved to treat diabetes, type 2 diabetes, was FDA approved to reduce kidney disease progression and cardiovascular death in people with type 2 diabetes. And then tirzepatide, as of December last year, the Zepbound, which is FDA approved to treat obesity, was also approved to treat moderate to severe obstructive sleep apnea. So if these medications are so great, why doesn't everybody take them? First of all, there's an issue with the supply and demand for these medications. Since they first came out, the demand for these medications have skyrocketed to the point that pharmaceutical companies that make them and the pharmacies that hold them can't keep them in stock. They can't make them fast enough. The other part is that these medications are incredibly expensive. If you try to pay out of pocket for these, on average, they cost between $1,500 to $1,600. You could go onto these discount coupon sites such as goodrx.com and find them for maybe a few $100s less. But obesity is a chronic disease. And so that means that every month you would be having to pay over $1,000 to get treated for this. And also, GLP-1 therapies have side effects. Common side effects with these medications are things like nausea, vomiting, acid reflux. You may experience changed bowel movements. Some people experience constipation. Some people experience diarrhea. Fatigue is also a common side effect. And they are contraindicated if you have a personal history of something called idiopathic pancreatitis. Pancreatitis with no known origin, or a family history of medullary thyroid cancer. And not only is it that it's expensive and that there are side effects and the supply and demand doesn't meet, but insurances can also be barriers too. For just the diagnosis of obesity, many insurances and their plans are very reluctant to cover these medications. So in the United States, even if you technically did qualify, you may not be able to get these medications because your insurance wouldn't cover it, even if you have a very reasonable medical reason for why you need this. Mass Health has been good about covering GLP-1 therapy. However, as of January this year as well, they started to put some more restrictions in that you need to have tried older medications, particularly phentermine, tried it and failed it in order for them to agree to cover for GLP-1 therapy, regardless of whether or not you have severe level of obesity, any other comorbidities, it doesn't matter. So insurances are a strong barrier to these therapies. So when we treat obesity, again, it requires chronic treatment because obesity is a chronic disease. That means that this is a disease process that can relapse and remit. It can get worse, it can get better with time, and it requires constant treatment because since obesity is a chronic disease, it cannot be completely eradicated. It is not like treating pneumonia or a skin infection. It's not like taking antibiotics for a certain period of time and then expecting that to kind of clear whatever it is that you had. You have to keep treating it. So we have to think about treating obesity the way that we think about treating any other chronic diseases, like diabetes, like high blood pressure, like cholesterol. You have to keep taking medication. You have to keep working on treatment for those, and you have to do similarly with obesity. So then does this mean that you'll be on medications forever if you are on medical therapy to treat obesity? Truly, at this point, we don't exactly know that answer. But there have been studies that have been done to look at what does happen if you stop taking these medications. A step 1 trial, it's called the step 1 extension trial, where people were taking semaglutide 2.4 milligrams, that's the Wegovy. They used it for 68 weeks and had a lot of weight reduction. And then they stopped the medication over a year later. What happened after they stopped the medication was that they regained 2/3 of their weight back. And that's over a period of about 120 weeks, but it could have extended further. You may have experienced further weight gain beyond that 120 weeks. And another study that looked at semaglutide again, the Wegovy, had people be on this medication, go up to the highest dose of this, up to 20 weeks, and then they switched some people to getting a placebo and other people continuing to get semaglutide. People who continue to get semaglutide continue to see good weight progression for 68 weeks. People who were switched to placebo regained that weight back. So even if we don't exactly know if you have to be on these medications forever, we generally know that if you stop these therapies, you will most likely see weight regain come back. So I want to bring us back into that definition of obesity again. The current definition stands in that it is a chronic, progressive, multifactorial disease process. Importantly, that it can lead to abnormalities. It can lead to physiological issues and functional issues. But as of this year, January this year, there was a new definition for obesity that was proposed from the Lancet by some international experts in this field. And what this new proposed definition says is that obesity is still a state of excess adiposity, but now we're starting to divide this into 2 main categories: preclinical and clinical obesity. Preclinical obesity is where you have excess adiposity, but you have preserved function of your tissues, of your organs, and your general physicality, but you do have an increased risk of developing clinical obesity in the future and other non-communicable diseases, such as the type 2 diabetes, hypertension, cardiovascular disease, mental disorders, certain types of cancers. And clinical obesity is a state of excess adiposity, but also a chronic systemic illness that is characterized by alterations in the function of your tissues, your organs, the entire individual, or a combination because of that excess adiposity. So with the current definition that we've been using till now, we generally use BMI as just kind of the standard to determine whether or not somebody has obesity and the severity of it. This new definition now says BMI is not enough. And we've always known that BMI is not really enough, but we've not really kind of had other ways that we had kind of extended beyond that. But now this new definition proposes that not only do you need a BMI, but we need other measurements of your body to determine that level of excess fat mass, that excess adiposity. So in order to do that, the gold standard would be really to get imaging, things like the DEXA scan or an MRI. But that's not really practical. It would be very expensive to do every time you went to go see your doctor to get these imaging done. And it's also not easy to obtain. Instead, you can get measurements done at your doctor's office by getting an anthropomorphic data. Things like waist circumference, a waist to hip ratio, or a waist to height ratio. If you can't for some reason get a BMI, then you can get 2 of the anthropomorphic measurements, the waist circumference, waist to height ratio, waist to hip ratio, to confirm the diagnosis of obesity instead. And if your BMI is above 40, you don't need to get the anthropomorphic criteria because we assume that there is excess adiposity with a BMI of greater than 40 because that is a more severe level of obesity. So visually, this is the main difference between preclinical and clinical obesity. Preclinical obesity and clinical obesity both have excess adiposity that is confirmed with a BMI and another measurement. But preclinical obesity, while there may be some changes happening in the cells and the tissues and the organs, It's not actually showing by any measurement that we can see in your lab work and your physical function. Whereas clinical obesity not only have those alterations, but it has also led to clinical manifestations. We can see that. We can see that in the blood work. We can see that in the person themselves. And so what these kind of complications and signs and symptoms of clinical obesity should be, basically what this slide is just showing is that there's a lot of different ways that we can look at it. We're not going to go into this in detail, but you can have issues from, the brain, from your lungs, from your heart, from your liver, your kidneys, reproductive organs. There's a lot of different ways that obesity can manifest. And what the difference between the prior definition of obesity was, or what the current is, compared to this proposed new definition, is that the current definition suggests that obesity is a disease of excess adiposity that can lead to problems in the future, whereas the proposed definition is stating outright that obesity itself causes illness, that it causes clinical issues. So then how would this potentially affect us? How does this impact treatment? Right now, we are still using the same BMI criteria, class 1, class 2, class 3, in order to define the levels of obesity. And that if you want to be, that if you are a candidate for medications, you either have to have one of those classes or also a BMI of 27 with an obesity-related comorbidity. But now, the new definition proposes that we do have to confirm that excess adiposity, that the weight is no longer enough, comparing that to the height. And regardless of whether you have preclinical or clinical obesity, obesity should still be treated. But maybe we don't necessarily have to jump to medical or surgical therapy. And maybe there needs to be more of an emphasis on the intensive medical treatment, including the meal replacements or working with specialists such as dietitians or exercise physiologists. But in a world with infinite resources, ideally, GLP-1 therapy would be freely available. But as we discussed before, there are a lot of barriers to this. And so because of that, while obesity does still need to be treated, that may not always be, these medication options may not always be accessible. Currently, we haven't seen, at least in the state of Massachusetts, that there are any changes to insurance coverage based on this new definition. But potential changes that could happen are that there could be further limitations for coverage with insurances for the disease process of just obesity itself without any other comorbid conditions. So then if you have preclinical obesity, meaning obesity without any clinical manifestations, we may have to consider using older anti-obesity medications, the phentermine, topiramate, bupropion, naltrexone, because those don't generally require insurance approval in order for us to be able to obtain them. They're just cheaper. And with clinical obesity, the obesity with clinical manifestations of illness, that might be more restricted, that insurance is maybe more willing to cover these medications for GLP-1 therapy. That being said, there are so many more research and trials ongoing about the benefits of GLP-1 therapy for other disease processes. And so we might actually see that there's an expansion of coverage for GLP-1 therapy for other diseases like cardiovascular disease, obstructive sleep apnea, renal disease, fatty liver disease, also very fancily named metabolic dysfunction associated steatotic liver disease. There's also been some studies looking into how GLP-1 therapy may help with disordered eating behaviors, and the list goes on. So we'll truly just kind of have to see. And not only is it that these GLP-1 medications are effective and beneficial for treating obesity, there are also new medications that are on the horizon. I present just a few. One is a medication called retatrutide, which is a triple agonist. So if you remember, tirzepatide or Zepbound and Mounjaro is a dual agonist. It comprises of a GLP-1 and a GIP. Retatrutide is that dual GLP-1 and GIP, but also combines a third receptor agonist of a glucagon receptor agonist. And this triple agonist has been shown at maximum dose over 48 weeks to contribute to 24% weight loss, which is a little bit higher than the tirzepatide at the maximum dose of about 20 to 23% weight loss. Orforglipperon is a daily oral GLP-1 pill that you can take. Studies with this have shown about 12 to 13% weight loss, which is still a little bit lower than semaglutide injections at 15 to 18% weight loss. But significantly, it also is associated with a higher level of nausea. About 60% of participants struggled with nausea compared to maybe about 30 to 40% that struggle with nausea with the injection medications. And CagriSema is another weekly injection, which is a combination of something called cagrilintide, an amylin analog, and semaglutide, which is a GLP-1 therapy. That has been shown to have a almost 23% weight loss associated with it, which is higher than just the semaglutide at 15 to 18% weight loss. But whether it's these new medications that are on the horizon or the current existing ones now, in order to consider medical therapy for obesity treatment, you need to meet criteria. It is inappropriate to use these medications in persons who do not qualify medically for obesity treatment. But there's a lot of social media buzz about it. Because of the shortages that have been happening due to the supply and demand issues with these medications, compounding of these medications had been legal. Now it's kind of starting to change because medications like Zepbound are no longer in shortage. But then that allows companies to be able to promote things like this, where they say that you can use these medications to get summer ready. That itself is not how that's not how we're supposed to be using these medications. That's not what it means to treat obesity. But also, the concept of using these medications short-term for short-term benefits can have long-term consequences. One is that you can experience weight regain, weight rebound from stopping these medications if you're using it for short-term benefits. It could also be worsening the stigma against obesity. Treating obesity is difficult, not just from a pathophysiology perspective, in that it is a complex disease process, but the way that people think about obesity as a society is very incorrect. And there's a lot of self-blame associated with that it's something to do with willpower, even though that's not the case. And when we use medications like these to promote things like short-term benefit, getting summer ready, that perpetuates that stigma against obesity treatment. And not only that, but it also affects other people's abilities to be able to access medical therapy, especially because these medications are in such high demand. So again, we're looking at this graph that shows that if you do use it short term, and then you stop taking the medication, you can regain that weight back. So when we use medications to treat obesity, there are 4 things to keep in mind. One is that medical therapy is a really effective tool to treat obesity, but you have to do it with lifestyle intervention. You have to improve your nutrition. You have to work on mental health. You have to exercise. You have to try to get good sleep. These medications are not going to substitute for any of that. And so that's the second point, is that anti-obesity medications cannot substitute for adequate exercise and nutrition. When you lose weight, however you lose it, you are generally just losing body weight. That comprises of fat mass and fat-free mass, such as your muscles. So then the body composition can change with a lot of weight loss. And because these medications are having an impact in that gut-brain axis that affect hunger and fullness levels, if the medication is too strong, that could actually lead to such a high level of appetite suppression that we would now be concerned about malnourishment. So we have to use these medications carefully, and we have to use it with adequate lifestyle changes. The third point, as I've emphasized during this talk, is that medical obesity treatment is chronic. Whether it's truly a lifelong medication still remains to be seen. But generally, the maintenance of weight loss requires continued use of therapy, of whatever therapy it is that you're using. And with medical therapy for obesity treatment, plateauing in your weight loss is normal. It is expected. And where you would plateau, where you would maybe stop losing weight depends on the type of treatment that you're using, whether it's an injectable medication or an oral medication, as well as your individual response to the therapy. So just because on average people might lose 15 to 18% with semaglutide does not necessarily mean that you would be in that category. We would just have to see how you respond. And so when we understand what obesity is, we understand it as a chronic disease that causes illness because of the excess adipose tissue that leads to metabolic and physical dysfunction. It can happen at any point in your life. You don't necessarily have to have it from childhood in order for you to have this disease process. It can get better, it can get worse. Generally, it is multifactorial in that there's no one good reason for why this happens. Generally, there are many different aspects of your life, of your history, of your family, your genetics that may contribute to your risk of developing this. And treatment for it is lifelong because obesity itself is a chronic disease and it is lifelong. Treating obesity means that it requires combination therapy of lifestyle changes with nutrition, physical activity, and the medication and surgical intervention as needed. And the goal of treating obesity are going to be moving targets. So the purpose of treating obesity is to improve your general health. It is not to reach any particular BMI or any particular weight. And the goal of this depends on your age, your metabolic health, where we started when you started treatment, as well as any physical limitations. So treating obesity is also not the elimination of hunger or cravings. It is normal to feel hungry. It is normal to experience cravings. And it is also not an idealization of a BMI, of a weight, or a body type, or any clothing sizes. So truly the purpose of treating obesity is to improve your overall health. Thank you so much. Any questions? Yes.
Yeah, thank you for the general introduction. I just have a point of clarification and a question after that. Under the label of off-label medication, there's an antidepressant that may help you with. But I think in the beginning, you showed that the antidepressant can increase obesity. So this goes both ways. Is that right? If I remember.
That is a great point. So generally, antidepressants are also, they have multiple different categories. So one is a selective serotonin uptake, reuptake inhibitor, a serotonin, that's an SSRI, and then there's another one called an SNRI. Bupropion, which is an antidepressant, falls into neither of those categories. So specifically medications like SSRIs, the selective serotonin reuptake inhibitors, have been shown to cause weight gain, but bupropion is not one of those medications. Bupropion is actually one of the only antidepressant medication that has been shown to have weight losing potential.
But yet on the clarification is the new criteria for obesity. It's I want to continue with anthropometric, but you said anthropomorphic. Do you use them interchangeably? I think they're different.
Anthropomorphic measurement just means the human body measurement.
Right, but anthropometric, as I saw on the slide. Yeah.
I think they are interchangeable.
Okay. The question is, there's one aspect that is relatively new is the microbiome in GI tract as it affects the health on multiple fronts, including obesity. For example, it regulates the digestion of food and hormone production. But it's not inconclusive because it's relatively new. Do you want to say something about that?
I think it's exactly as you said, is that there are no particular data that point in any particular direction or whether the prebiotics or the probiotics have been shown to have significant impact on the treatment of obesity. And so I know that there's a lot of interest in terms of, fecal transplants or, taking prebiotics and probiotics and whether that will help you treat your obesity. nothing has really actually been shown to have a significant impact. That being said, there are certain levels of certain type of gut hormones that have been shown that maybe having a certain level of one type of gut hormone versus another may increase your risk of obesity. But again, that's just a risk. It's not necessarily to say that it will absolutely cause obesity.
Okay.
So we have a question from Zoom. It seems like surgery would be the better weight loss treatment in the long run if medications have to be lifelong. Are there more recent statistics comparing surgery with the weight loss medications?
There aren't any what we call head-to-head trials where we're looking directly at the effect of medication versus surgery, but in general, metabolic and bariatric surgery does tend to be overall more effective from a percentage of weight loss compared to any of the medications that we have on the market currently.
All right, thank you. And another question from Zoom. Any emerging therapies in alternative and complementary treatments?
Not a strong data. I mean, are you meaning things like supplements or again, like the probiotics?
Unclear, but I would say if you can address those.
Yeah, so there are no supplements, there are no probiotics or prebiotics that have been shown to have significant weight losing potential. Truly, the options that I had presented today are kind of the mainstay therapies. That being said, from an alternative perspective, that's I think where we need to kind of focus a little bit more on the lifestyle interventions. So in one aspect, high protein diets have been shown to be very protective against muscle mass loss. Generally, if you have any type of diet that you follow, whether it's a low fat, low carb, Mediterranean DASH diet, and you have weight losing potential with those, about 20% of 20 to 25% of what you might lose is a lot of muscle mass. High protein diets have been shown though to help protect that loss against muscle mass.
That's great to know. All right. Any other questions here in the room? If not, I'll ask. I'm just curious to know how you landed in this specialty.
So because my background is in family medicine, obviously, or maybe it's not obvious, I've always had a strong interest in preventative therapy. I think that's something that our healthcare system does not do a great job at. So chronic diseases and treating chronic diseases was always something that I was very interested in. In residency, actually, there was an opportunity for me to follow in a particular pathway to treat specifically obesity. And so I had worked with a specialist at the University of Chicago and just became very interested in how this one disease process has such a impact in every other aspect of your life and of your health. And so while treating other chronic diseases is incredibly important, I found a lot of satisfaction with treating obesity because I've seen how it has such a huge impact in someone's overall health, and I've seen how other specialists have responded very positively to the obesity treatment.
And actually, sorry, I have another question. Does the Weight Management Center conduct research itself?
We need to do more of that at this point. I think we're looking into doing some more clinical trials. I think so there's a Mass General Weight Center and there's a Brigham Weight Center. I think there are some trials ongoing at the Brigham Weight Center, but we are actively trying to engage in more clinical trials at the Mass General Weight Center.
Great. All right. Well, with that, let's thank Dr. Mulligan. Thank you so much.
Thank you.
Thank you so much.